thank you for inviting us to present this. Just to explain, this was a presentation that Clara and I gave at the Best Practice Day in Cardiff. And unfortunately, there was a technical error, which meant that some of the presentations were not recorded. So we're now recording this after the event over Teams. So our presentation was about the development of the Dental Antimicrobial Stewardship Programme at Betsi Cadwaladr University Health Board. I'm Katherine Mills. I'm a dentist who works as an educator based in North Wales. And my colleague is Clara Tam, who's the lead antimicrobial pharmacist at Betsi Cadwaladr University Health Board.
Hello, everybody. We'll go straight into our presentation then. So before we go into the details of what we have done in BCUHB about on antimicrobial stewardship in dentistry, I thought we'll give a bit of background of what is the global picture and what is why are we doing this, contributing to the bigger picture. So the World Health Organization has listed the antimicrobial resistant issue as the top 10 global health threats. And in 2016, in the UK, the Prime Minister at the time has asked Jim O'Neill to do a report on what is the global impact. And he came out with the reports with the data of reporting by 2050, there's going to be 10 million deaths contributing by antimicrobial resistance and costing the healthcare system 66 trillions. And within his report, he also says about comparing antimicrobial resistance against all the other reasons that could be causing deaths, for example, cancer and diabetes. And as you can see from the graph, that cancer, 8.2 million, plus diabetes 1.2 million altogether is still less than the impacts that can cause by antimicrobial resistance of 10 million deaths by 2050. There's also other data that has been done by the Antimicrobial Resistant Collaborator. It was published on the Lancet in 2022. So in 2019, they have done a systematic analysis looking at the whole world of the impact of antimicrobial resistance to the whole world globally. So the results came out as nearly 5 million deaths were associated with bacteria antimicrobial resistance, and nearly 2 million deaths were directly attributed by bacterial antimicrobial resistance. So by looking at this figure, we could see that the estimation done by Lord Jim O'Neill wasn't an overestimation, as some people suggested, if you already got 5 million deaths in 2019. So that was the global picture, but what is the UK doing about it, and how could dental fit in? So there is a 5 years national action plan, and actually it was from 2019 to 2024, so it's quite nearly due for review now. But within that report, within that action plan, in section 3, it's indicated optimal use of antimicrobial in human, and there's a target set that by 2024 there should be a 25% reduction in total antimicrobial usage in the community compared to the 2013 baseline. And that's where Right Dental could fit in, because dentists do prescribe in the community, do prescribe antibiotics in the community. And that has been our antimicrobial resistant improvement goal for a number of years as well, aiming to match the goal in the National Action Plan. So I'll hand over to Katherine to talk about what is the situation in dentistry at the moment.
Okay, well, I think it's fair to say that dentists are pretty aware that we should be prescribing less antibiotics, and in fact, we've already taken action to do that. And we were, in fact, the first country in the UK, in Wales, to have a dental antibiotic prescribing audit, which has been modified in the last couple of years, but is still running. So I think it's fair to say that we're aware of vaguely what we need to be doing. But that we are, if you can change this slide for me, Clara, we are really quite blissfully unaware of the much bigger picture of antimicrobial resistance and what's being done to tackle it. Okay. So dentists are in the 10% club, and the reason we're in the 10% club is that we prescribe about 10% of all the antimicrobials that are prescribed in primary care. And over a quarter of a year, at the last quarter of 2022, that was about 41,500 items. And that's quite a lot of prescribing going on. Okay. And we know that that picture is pretty much the same wherever you look in the world. Dentists write about 10% of all the prescriptions that are written for antibiotics. Unfortunately, various publications have already been done out there showing that up to 80% of the antibiotics that we prescribed are inappropriately prescribed. In other words, we aren't doing great antimicrobial stewardship, and that's a concern. So let's have a look at the picture of where we are. If you look at the target that was set for the dental profession over its 2013 baseline, we have to try and do a 25% reduction by 2024. And that's our target rate. But when you look at where we actually are, which is the blue line, we've already hit the target. We hit it back in 1718. So dentistry was really doing pretty well. And we'd already hit the target. Aren't we great? So no problem here, yeah? Unfortunately, that all changed during COVID because this is what happened. Instead of carrying on dropping down, staying well below our target rate, there was a massive blip in antibiotic prescribing during COVID. And I don't think that comes as any surprise to anyone working in dentistry, given the constraints that we had to work under. But the good news is that we have actually now gone back to being below the targets that are set for us. So that's good. But there was a couple of years where we were above where we needed to be. And so people started looking a little bit more at what was going on in dentistry. Okay. So just to explain a little bit about antibiotics in dentistry, and just a warning for those of you who are dentally a bit squeamish, you probably want to look away because there will be a few pictures coming up. Okay. So basically, with acute dental infections, here are some pictures of some of the things that we come across. And I think you can see here that we've got some lovely little swellings going on around teeth, swollen faces, little lumps on gums, and a gum abscess there. So these are the kinds of things that we get asked to treat quite regularly. Okay, so what are our options for treating these infections? Well, essentially, it doesn't matter what the type of infection is. We need to drain the pus. Never let the sun set on undrained pus, I was taught in dental school. So how do we go about draining the pus in these situations? Well, we've got the option of draining it through the gum, through the oral mucosa. And at the beginning of COVID, there were some questions about whether doing this was an aerosol generating procedure. So there were some concerns about that. But you can see what we do. A scalpel's popped in, suction goes on, and all the pus goes up the tube. Lovely, and almost instant relief for the patient. On the left-hand side here, you can see an X-ray showing a dental abscess, that dark area underneath the roots there. And an obvious way we can drain the pus is to take the tooth out. And you can see in the picture on the right that on that particular root, the abscess has actually come out attached to the bottom of the root. And that immediately solves the problem, and we don't have to worry about antibiotics. And the final way that we can drain pus is to actually drill through the tooth. So if you can see the abscess at the bottom there as before, this tooth, you can see something that looks a little bit like a butterfly in the middle of that tooth, and that's the nerve and the space where the nerve is. So what we do is we use a high-speed handpiece and we drill down through the top of the tooth until we can see the space where the nerve was and look down into the roots, into those root canals. And in this particular case, there are 5 root canals, so this must be a private root canal treatment because there's normally only 3 on the NHS. Okay, so what we do then, we can see down the root canals. We take an instrument, something like this, and we poke it right down inside the tooth. And with a little bit of luck, we get the result of some nice pus coming out. So that's another way that we can drain the pus without extracting the tooth. And that tooth is going to require root canal treatment in the future, or possibly extraction after things are settled a little. Okay. So during COVID, you can imagine if you had a dental abscess on a front tooth like this, we couldn't do aerosol generating procedures. So we weren't able to pick up our high-speed handpieces and drill a hole in the tooth in order to relieve the pus. The only options we had, if there wasn't a nice swelling, a nice obvious swelling to pop, was to take the tooth out. And you can understand that a lot of people didn't want to have their teeth out. So it's not really surprising that dentists felt they had no choice other than to pick up the prescription pad and write prescriptions. Okay. So when we look at what antibiotics dentists actually do prescribe, of that 41,500 items in that quarter, we can see that far and away the vast majority of the antibiotics prescribed are amoxicillin, followed by metronidazole, and then a bit of Pen-V, a little bit of erythromycin, and then a very small proportion of our antibiotics, about 2% are the others. But that does include some of what you know as the 4C antimicrobials, clindamycin, coamoxiclav, and cafalexin. We don't prescribe an awful lot of them, around 600 or 700 maybe, but we know that these are the antibiotics that do drive antimicrobial resistance. So dentists can prescribe those, although we don't tend to do it very much. But bottom line is, whatever we're prescribing, we know that antibiotics are known to drive the spread of antimicrobial resistance. So whatever we're prescribing, it's adding to the problem of spreading antimicrobial resistance.
Thank you, Katherine. So as Katherine already nicely described, the aim of us, the message that we wanted to get to dentists is not about what antibiotics we are using, whether it is resistant in dentistry, because we're probably not seeing a lot of resistant or treatment failure using what we are using at the moment in dentistry. However, what we are prescribing in dentistry are contributing to the bigger picture. And we got a slide of antimicrobial resistance in urine culture report. It's annual report that Public Health Wales publish, gaining data from all the health board. So for example, here is an E. coli resistant report in urine culture, and we can see that amoxicillin has a really high resistance now, and it's about 58.2 resistant by 2022, and coamoxiclav is about 44.6 resistant. And they might not all be caused by dentists prescribing, but dentists do prescribe those antibiotics, and we are all contributing to the resistance to these kind of bacteria in the report. So what can we do about it? So we sat in the team and with dentists and the antimicrobial team, pharmacy team, and also with microbiologists, and we looked at all the resources available at the moment, and we chosen to use this one published by the Federation of Dentistry, the essential role of the dental team in reducing antibiotic resistance. And within there, it suggested a combi model that's looking at what is the contributing factor that will lead to a change of behavior. And immediately we spotted a few things that could be something that we could quickly do. So this antibiotic awareness, guideline and information, and any practice gap, which we'll go into it with Katherine's presentation later about what she found from her audit. And access. By access, we mean like is the guideline easy to access, and is the prescribing data accessible to people so that people can reflect on their own practice. So I'll hand it over to Katherine to explain what she found from her audit.
Okay, so I did a couple of things. I did an audit, and it wasn't a huge audit, so please be mindful of that when we are extrapolating results. But what I did was I looked at the dental records of 10 different dentists from all across primary care, some community, some in practice, some offering urgent dental care sessions and so on. And I looked at a sample of dental records made by those dentists at the time that they wrote a prescription for antibiotics. Basically there, what I found was, if we go through that, sorry, if we can just go to the next slide, sorry. The other thing that I did was I also got some high-level data from colleagues in Public Health Wales about all the prescribing of antimicrobials that had been done by dentists all the way back to 2013. And that was a massive, it just came as one massive spreadsheet with over 11,000 lines of data, which I then had to break down and work out. So that was about 4 days of my life I will never get back again. And I've really barely skimmed the surface, but there was some very interesting information in there. So what I'm going to tell you about what I found is based on either my audit or that. So what I found in my record keeping audit is that some antibiotics were being prescribed for diagnoses which are inflammation. As we know, antibiotics don't treat inflammation, they treat infection. So things like periapical periodontitis, which is an inflammatory condition and a dry socket, you wouldn't really be expecting to have antibiotics prescribed for those. Now, some of the things I've coloured yellow in here, and they're things, if you look at them, a diagnosis of pericoronitis or ANUG might suggest that an antibiotic is appropriate, but not always. So looking at that a little bit further, if we could have a look, I just wanted to explain what those things are. Pericoronitis is an inflammatory condition. It means inflammation of the tissues around the crown of a partially erupted tooth. So you get a partially erupted wisdom tooth like this, and it has a little flap of gum called an operculum over the top. And what happens is a bit of food might get stuck under there, it might get a bit traumatized, it might be that the tooth opposite bites against it, and it becomes a bit sore and swollen. But it is purely an inflammatory condition. And we treat it basically, if you can just move to the next slide, we treat it by irrigating underneath that flap with either some sterile saline, or some people like to use a Corsadol mouthwash, and they'll flush underneath there to flush out any food. They might stone a little bit off the opposite tooth to stop it biting against that bottom flap. And we can do local measures to put it at bay. So it doesn't always mean that there needs to be an antibiotic. However, it can become infected, and we get particular anaerobic bacteria. And we know that we've got an infection there because we'll suddenly see much more severe, diffuse or increasing swelling. Lymph nodes tend to come up. The patient may not be able to open their mouth properly. That's what trismus means. They may have a bit of a temperature. They may have tissue swelling. So when that sort of thing is around, absolutely fine, no problem. An antibiotic is almost certainly indicated on top of those local measures. But the diagnosis of pericoronitis on its own does not necessarily mean that the antibiotic was appropriate. The other condition that I mentioned there, which can be doesn't always need an antibiotic, is one called acute necrotizing ulcerative gingivitis. It's got loads and loads of names. I think the latest one is necrotizing periodontal diseases. Now, this isn't a picture of necrotizing periodontal disease. These are healthy gums. They're pink, pale, stippled and firm, and they don't bleed when you brush them or touch them. And I think you can see straight away the difference between that and the picture above. Now, the picture above still isn't a necrotizing periodontal disease. This is basically gingivitis, chronic gingivitis, caused by poor oral hygiene. The patient isn't removing plaque from around the edges of the teeth where it meets the gums. The gums have become a bit red and swollen. They probably bleed quite easily. I think you can see the difference between that and this on the right. Now, this is necrotizing periodontal disease or acute necrotizing gingivitis. You've got actual destruction there of the triangles in between the teeth. It looks pretty uncomfortable. It is not very nice for the patient. It's extremely painful. You can smell them when they walk into the room. You just know you've got an ANUG case as soon as the door opens. It can be too uncomfortable for the patient to go anywhere near that with a toothbrush. And interestingly, it's caused by the same anaerobic bacteria as pericoronitis. Usually it's the same sort of group of bugs. And if it's severe and there's, systemic involvement as well, then the treatment for that would be trying to do some cleaning if the patient can cope with that, and giving some metronidazole to kill off the bugs, or amoxicillin is the second line for that one. But just having a diagnosis of acute necrotizing ulcerative gingivitis does not necessarily mean that it's appropriate to prescribe. And what I found was that there's this guideline called NG15 from NICE, which states very clearly that not only a diagnosis, but a reason should be given for prescribing. So I was looking to see whether that was present in the notes as well. And the reasons should justify why the prescription was appropriate. And these are the things that generally are written in the guidelines about when it's appropriate to prescribe for dentists. So it's if there's significant increasing severe or diffuse swelling, trismus, which as I mentioned already is that it can't open the mouth, cellulitis, which is tissue swelling, lymphadenopathy, which is a raised lymph nodes showing that there's spreading infection, or systemic symptoms such as a raised temperature, feeling tired, feeling unwell. But just having the diagnosis on its own isn't always enough. So were the reasons in the notes appropriate or clear? Well, I found that about 29% of the time there was a good reason given, and you could say, yeah, that's justified. That prescription was justified in that case. But what I found as well was that it wasn't always very clearly done. And in some cases, it clearly wasn't appropriate. And where people had just written swelling, I think it's just worth looking into that a little bit more, because sometimes you could say it was, sometimes you could say it wasn't, but a lot of the time, actually, you couldn't really tell whether the antibiotic had been prescribed appropriately or not. Okay. So the bottom line out of this, I think, is basically that dentists do need to keep better records around their antimicrobial prescribing, so that during audits and things, it's much easier for them to see why they did what they did. The guideline terms that we came across in the NG15 were things like diffuse, severe, and increasing swelling. So just to look at that a little bit more, we've got 4 swellings here. The swellings on the gum, I think they're fairly obvious. Now, none of these is diffuse, severe, or increasing. These are localized swellings, and the appropriate treatment here usually is either to take the tooth out or to just get the to drain the pus. And you wouldn't normally be looking at prescribing antibiotics for these. So just writing swelling doesn't necessarily mean that the antibiotic was appropriate. This is a more localized swelling in the gum next to this particular tooth. And again, you might think, oh yes, that will definitely justify an antibiotic. But in fact, in this case, there was just an abscess on the premolar tooth there with the filling in it, the little black dot. It wasn't possible to restore that tooth. It was so badly broken down inside. And the correct treatment there was just to extract the tooth. And if that is extracted, then there is no need for antibiotics. And this case here, you think, okay, fine, we've got swelling on the lower right quadrant there. Maybe, that's actually a bit visible on the face. We've got some facial swelling. But the question we get then come down to is, well, can that patient actually open their mouth to receive treatment? And if they can, and the treatment can be done, then extracting the tooth or teeth that are causing that swelling, again, would be the appropriate thing to do rather than automatically give antibiotics. And in this case, that is what should be done. Just extract the broken roots there, and that swelling will resolve without any antibiotics. So just writing swelling in the notes doesn't necessarily mean it's justified. There are some swellings where clearly it is absolutely unquestionable that antimicrobials and probably secondary care are going to be needed. When we've got a big swelling like the one on the left heading down the throat and is affecting swallowing or breathing, where we've got a swelling like the one in the middle that's crossing the midline of the jaw, that is very concerning, because we know that can affect breathing, swallowing, and contract down the mediastinum and cause a problem further down in the chest. And when we've got problems there, we've got a swelling that's starting to close the eye. Those are all cases where you'd definitely be thinking, yep, antimicrobials definitely justified here. But to be honest, in most of those cases, possibly with the exception of the child, you'd probably be sending them straight to secondary care for treatment anyway. So the things, as I say, it's appropriate when there is lymphadenopathy, systemic symptoms, trismus, cellulitis, or severe significant swelling. Okay, if you were squeamish about the pictures, it's safe to come back in the room. The other thing I found through my audit work and through the higher level work is that we're not always following the guidelines that we have. When it comes to choosing the drug, what we found was that in June 2021, the Scottish Dental Clinical Effectiveness Programme issued new guidance for the management of acute dental infections and sinusitis. And they stated in those guidelines that where antibiotics were required, we should be giving penicillin V, as our first line antibiotic. That was because of better antimicrobial stewardship reasons, basically less likely to drive the spread of antimicrobial resistance. So when we look at whether that's been followed or not, I looked at those all Wales figures that I had going back to 2013, and this is how the prescribing of Pen V by dentists over that period. So you can see when the statement first came out from the Scottish Antimicrobial Prescribing Group that they were going to change their advice from amoxicillin to Pen V, you can see that after that statement was released, there was a bit of a jump in prescribing of Pen V. And when the actual update was published in June 2021, again, there was a bit of a jump in penicillin V prescribing by dentists. So on the surface, that looks really good. You think, okay, we're doing something about this. But when you look at the bigger picture and you look at how much Pen V was being prescribed over the period from 2019 to 2022, so during the period of this change, compared with the amount of amoxicillin, and again, you can see that jump that happened during COVID, you can see really it hasn't been very widely taken up by the profession at all. And if you ask people about it, they're generally just not aware that it changed. We also find that guidelines are not always followed in terms of the duration of the antibiotics. And over the period that I was looking at, the SDCAP had clearly said that for AUG and pericoronitis, the conditions I showed you earlier, we should be prescribing metronidazole as our first line, 9 tablets. So that's 1 3 times a day for 3 days. When you looked at what was actually being prescribed, I was very surprised to find an awful lot of metronidazole was being prescribed for 7 days, which actually doesn't appear in any guidelines whatsoever for dental infections that I can find. And if we just look at the number that were actually being prescribed for 3 days, it was really, really low. So even with these simple things that we're prescribing, changing Pen V for amoxicillin, reducing the duration of our doses of metronidazole, we're not really doing it. And I did have a look to see whether that in the high level data, I could see any evidence of reduction of doses of metronidazole over that period by dentists, but it's difficult to get it out from that data because we don't actually look at data in that way. We look at the number at the DDD per item, but you would expect if we were having shorter durations that the DDD would reduce. And you can see there was a jump when the recommended dose of metronidazole for adults jumped from 200 milligrams to 400 milligrams. You can see the DDD going up very clearly there, but there's certainly no sign of it reducing again, where some prescriptions are recommended for 3 days instead of 5. So there's certainly no clear evidence. And the other thing that my work found was that the national guidelines for dentists don't actually match. Now, at the time I did the audit, I was looking at the SDCAP guidelines because those were the most current ones. But since then, in November 22, we had a new synopsis published by the Faculty of Dental Surgery, the College of General Dentistry. And I'll just highlight for you 2 of the things where it just doesn't match, and they're on really common things. The Pen V that I mentioned before, yes, we are saying, SDCAP is saying we should definitely be prescribing Pen V as our first line, but the CG Dent guidelines, although they mention Pen V, they just say that or amoxicillin. There's no clear steer towards Pen V, so they don't match in that respect. And when you look at metronidazole, as I said, SDCAP very clearly should be a 3-day course of either metronidazole or amoxicillin for those conditions. When you look at the CG Dent guidance, they're saying the doses are the same, but they're saying up to 5 days. So again, despite the NICE guidance being we should prescribe the shortest effective course, that isn't being reflected in the guidance that's the wording of the guidance that's being come out from the College of General Dentistry. So I'd identified quite a lot of practice gaps basically between where we are now and we perhaps ought to be as a profession. There were poor records of the diagnosis and the reasons why things were being prescribed, and also discrepancies in the drug and the dose that was being prescribed and the duration. So quite a lot of practice gaps identified there.
Thank you, Katherine. So as Katherine nicely explained, there is various different guidelines nationally. So when we identified that, we decided to produce a local antimicrobial dental guideline, which we included our microbiologists to gather local resistant data to make sure that our BCU population have the best antimicrobial that will respond to the infection that most likely causing the infection. And this dental antimicrobial guideline is accessible through the platform called MicroGuide app, and it's an easy downloadable app on your phone, and you can access it anytime. And the other thing that we decided to do, remember we talk about access, it's not only about accessing guideline, but how easy it is for dental advisor or dentists to have a look at their own prescribing data and comparing themselves with the other colleagues. So we decided to have a database that reflects this kind of data. So as you can see, there is various chapter that we have developed. So we have developed a chapter level analysis where they divide the drug that dentists prescribe by BNF chapter, and the yellow line here, as you would expect, is the infection chapter. So dentists mostly prescribe antimicrobials for infection. And other chapters, we can look at it by drugs. So we can also see what kind of drug that they prescribe the most. And as Katherine already identified from her audits, that amoxicillin is still the most widely prescribed antibiotics within dentistry. We can also look at it by dentists to see which dentists prescribe the most antibiotics, and within that, what antibiotic that they prescribe the most. So after we set ourselves a few standards and some measurements, we wanted to measure how by the end of the year, April 2024, how well we will be achieving what we have set out. So these are the three standards we have set, a target that we have set ourselves. So as Katherine already identified, that we should be using phenoxymethylpenicillin, not amoxicillin in most dentists dental infection. And that can be measured by the database that we have just shown you. And the second is the access of the local dental guidelines. So we're hoping to see increased use of this guideline by dentists, and also keep in line with the national action plan with the 25% reduction of dental antimicrobial prescribing by April 2024. And that is ongoing data that can be generated by our local dashboard and also from Public Health Wales data. So how are we doing so far? We have recently got data from Public Health Wales, and the blue line here is our actual rate, and the orange line here is our target rate. So as you can see, we are actually already achieving the 25% reductions by only raising awareness and talking about it amongst the profession.
So from the work that I've done, I came up with some recommendations at different levels, really, which I've subsequently been taking forward. Looking on an all Wales level, one of the things that I felt, sorry if you can move that on, Clara, one of the things I found was that we didn't have a particularly good antimicrobial stewardship toolkit for Wales. We have our audit, as I said, it was a pioneering audit that we did back in 2013, but we've revisited that as a team, as a dental team in HEIW, and we've improved it now so that anyone doing that audit gets educated feedback on what they have put into the audit, on both their prescribing profile as a practice and their individual responses to 10 prescribing scenarios. So we've been able to raise awareness kind of on an individual basis or an individual practice basis, where we're seeing that they haven't picked up on the need to be prescribing more Pen V rather than amoxicillin, or where durations and things are not as the guidelines would recommend. But that's all we've got in our toolbox. We don't have any dental specific e-learning for Wales on antimicrobial stewardship. There is some all prescriber e-learning, but it's very, very doctor centred in terms of the scenarios that are there and the antibiotics that are discussed. We don't have any bilingual dental patient-facing resources for Wales. I always thought the Antibiotics Don't Cure Toothache campaign, for example, was a national campaign, and most dentists thought that was the case. It was certainly launched nationally by national bodies like the College of General Dentistry and the British Dental Association. But in fact, although we have these amazing posters that you can get at through Target, and you've got similar ones available in Scotland, Wales doesn't have them. It didn't support the campaign, and so we don't have any of those materials bilingually, which are required by law if we're going to display them in our waiting rooms and that sort of thing. We could do with some more dentist resources like that, really, some messages and things for our teams to be giving to dental patients to help them with their expectations about antibiotics. And we could do with some better patient education materials specific to dentistry in a bilingual format. Okay, if we could carry on. The other thing I found was that whilst we've got in England, we've got Scottish Antimicrobial Prescribing Group, and in England, we've got the SBAR group, which are both looking at antimicrobial prescribing. And both of those have got quite long-standing dental subgroups. Now, in Wales, we have our National Action Plan Delivery Board on antimicrobials, but we don't have a dental subgroup. And I think that's possibly why dentistry, to some extent, has kind of missed out on the links that it might have had with the other countries to be part of the national campaigns, by which I mean the UK campaigns that are going on. We do have our own. I'm not saying that we don't have things, but they generally don't include dentists very well. And we're not generally aware of the campaigns that are going on. And they are very busy. There are people in Public Health Wales doing campaigns right now for this November's World Antimicrobial Awareness Week and the European Antimicrobial Awareness Day. But generally, those messages are just kind of going over the heads, I think, of dentists. They're not really part of the bigger picture yet. And I think not having a dental subgroup may be part of the reason for that. I think perhaps we need to raise the profile much greater within Wales about the whole topic. And then, of course, locally, we've already talked about the microguide that Betsy's developed, the dental dashboard that they've developed locally, and Clara described some targeted initiative, including that very ambitious initiative to get Pen V prescribing above amoxicillin by next April. Everyone I've mentioned that target to just goes, really? I think that'll be amazing if you manage to achieve that, but why not set a great target? And it's better to aim high and nearly hit it than aim low and hit that, I think. So good luck with that one. We're certainly doing our best to raise levels of awareness. I've been jumping up and down since I've learned all these things and spoken to various quite high level people in Wales, including the Chief Dental Officer. I'm speaking to the Quality and Safety Group for all Wales quite soon. And we are having our own symposium on the 22nd of November on antimicrobial stewardship in dentistry in Bangor, which we are calling Antibiotics Don't Cure Toothache Discuss. And we've got some quite high level speakers coming to that, including Wendy Thompson, whose name you may well have noticed on several of the publications and the FDI booklet that we showed you earlier. She is Mrs. Antimicrobial Stewardship in Dentistry, so I'm really excited that we've got her coming to that event. Okay, so that was where we finished our presentation on the practice day. We did anticipate that, and quite correctly, that we would have a question about private prescribing by dentists. And we had prepared a short presentation where we could collect some information, but there just wasn't enough time for us to go into that. So I'm going to include that presentation now for those of you who would have liked to see it. So you are able to give us your views. This survey will be open until the end of December 2023. So if you would like to get involved and give us your feedback, just use your smartphone to use that QR code, and that will open up the survey. There's only 3 questions. It's not onerous. It's not like the census or anything like that. Okay, so moving on. So what about private dentistry and prescribing of antibiotics? Well, the bottom line is no, nobody is looking at it at all. So is there a requirement for anyone to look at it? Well, if we go back to that NICE guidance I mentioned earlier, NG15, the audience for that guideline definitely does include dentists, but it says that it may also be relevant to those delivering non-NHS healthcare services. So to me, that means it may be relevant to those providing private dental services. But the problem is with the language. May can equally mean may not. Now, dentists are used to 2 different bits of language. We're used to should, which implies best practice but isn't mandatory, and must, which implies it's mandatory. So I think if the powers that be really want us to look at antimicrobial prescribing in private dentistry, they're going to need to change that guidance from may to must. And either that has to come from NICE or it has to come from the General Dental Council. And interesting, the General Dental Council actually are very, very quiet on the whole subject of antimicrobial stewardship. It actually doesn't appear anywhere in their undergraduate curricula or anything. So there's some work to be done there by the GDC, I think, as well as NICE. So nobody actually knows the scale of private dental prescribing of antibiotics. I tried to estimate it, and this is what I came up with. I found a paper that gave figures for the southeast of England, which is where the majority, the more people than anywhere else rely on private dentistry, and that's 21%. So if we looked at NHS prescribing in Wales of 41,500 antibiotic prescriptions and assumed that that was 79% of all the patients, and we looked at the other 21% as having possibly private prescriptions, we would have come up with a figure of about 11,000 antibiotic prescriptions. That is very dodgy extrapolation. It could be way higher, it could be way lower. I've got absolutely no idea, but we'd be looking, if that was right, at about 3,000 private antibiotic prescriptions per month in Wales. But that assumes that people are writing private prescriptions in the same and presenting them to chemists in the same way that they're doing it with NHS dental, the green dental prescriptions. When a dentist writes a private prescription like this, it's taken to the pharmacy dispense it, and then they put the prescription in a box somewhere, and then after a suitable interval it is shredded. Nobody is scanning that information, nobody is collating that information, nobody is looking at that information. But there is another way that dentists can prescribe. So before I go into that, what I'd like to know is to ask you, a lot of you are pharmacists, a lot of you are community pharmacists, so you are handling dental prescriptions all the time, day in, day out for antibiotics. And what I'd like you to do is think about all those prescriptions that you dispense or handle, whether they're NHS or private, and just let us know in the survey, roughly what percentage of them do you estimate are private? So if you go to the survey and just give us your answer there, that would give us some idea of what the scale of it is, because we really don't know. The other way that dentists can dispense antibiotics to patients is directly. We are perfectly allowed to do that. We are allowed to dispense antibiotics directly to patients, and private dentists are not restricted to those on the NHS dental practitioners formulary. They can give any antibiotic they like. That's under the Human Medicines Regulations 2012. So I thought, well, okay, maybe there's a way of getting the data about private dispensing directly from the dental practices. But when you look at the records that actually have to be kept for antibiotics, there is no requirement to keep a separate log of all the antibiotics that are dispensed. There just has to be a record in the patient's clinical notes, and that's it. So it'd be very, very difficult retrospectively to get that data. You might be able to set it up to do it prospectively, and if NICE changes its guidance that it does want private prescribing by dentists to be looked at, then I don't think it would be that difficult to start collecting that data, but there's no way of collecting it at the moment. So the final questions I've got for you basically are just, what are your concerns or feelings around private dental prescribing? I was told there will be questions about it, there will be questions. So why? Obviously, there are concerns and feelings about private dental prescribing. So I'd like to know what that is. And the other question is, if you've got any other aspect of dental prescribing of antibiotics or antimicrobials, whether it's NHS or private, if there's anything you've observed or you'd like to feed back for me to think about, please use the space to do so. The survey is quite anonymous, I think, so I won't know who you are, but anything you've got to say, that would be really great. Like to hear from you. So it just remains for Clara and I to say thank you very much for your attention, and to say thank you also very much to everyone that's been involved with my work and with Clara's work, and enabled us to put this presentation together. And thank you also for inviting us to speak.